Thank you very much indeed. Professor Khan, to welcome Professor A. Venkatraman. Thank you very much indeed, sir. And Professor Khan, to welcome Professor T.C. James. A very warm welcome to you, sir. Thank you, Professor Khan, for doing the honors. So, ladies and gentlemen, the first presentation is by Dr. Kim Sung-Chol, who is the Regional Advisor for Traditional Medicine, WHO Southeast Asia Regional Office, New Delhi. And he is qualified in conventional and traditional medicines, Chinese and Korean traditional medicines, with MPH, and has worked as medical doctor and researcher in the National Academy of Korean Traditional Medicine, Koryo Medicine, in DPR, Korea. He also worked as medical officer in the Ministry of Public Health, DPR, Korea, and as a national professional officer for the health system development at WHO Country Office in DPR, Korea. And today he is going to present on emerging health concerns towards achieving the goals of WHO Traditional Medicine Strategy. And may I remind our eminent keynote speakers, the time duration is about 10 to 12 minutes each, and if time permits, we'll have question and answers in the end. So ladies and gentlemen, put your hands together to welcome Dr. Kim Sung-Chol for his keynote address.
Hi. Okay, distinguished participants, ladies and gentlemen, a very good afternoon. So first of all, I'd like to thank the Central Council for Research in Unani Medicine for organizing this wonderful event and giving me opportunity to make a presentation today. So since the theme of the Okay, since the theme of the today conference is the Unani Medicine for Public Health, so I'd like to a little bit touch on this, what is the public health concerns in Southeast Asia region, and why traditional medicine is important, and global traditional medicine strategy, and what is the key challenges towards achieving goal of the global strategy, and then regional response on it. So, okay, let me begin by talking about the regional public health concerns, particularly for achieving universal health coverage. As you know, that the goal of the universal health coverage is to ensure everybody to access good quality of the medical services based on when they need and based on their need, but without any financial problems. However, in the Southeast Asia region, still facing number of the challenges to achieving that goals. So for instance, that many countries still facing that shortage of the human resource for health. For example, that global targets, that human resource for health is 44.5 among 10,000 population. But our region just to only that 27.1 at the moment. So which is quite far behind from the global targets. And also you can see that, non-communicable disease also increasing year by year, and especially, more than 64% of the overall deaths is because of this non-communicable disease. And especially more than half of them actually occurred during the age of 30 and 70, which is considered most economically, productive age groups. So this premature death actually impose huge negative impact, on the social and economic development of the Southeast Asia region. And also people are spending a lot on these medicines. So this number actually is almost equal to the modern allopathic medical practitioners. So there is a huge potential in traditional medicine can, coping, overcome those, our regional, public health challenges. So that's why WHO endorsed global traditional medicine in 2014. So this is the goal of the WHO Global Traditional Medicine Strategy. So there are two goals. One is harnessing potential contribution of traditional medicine to health, wellness, and people-centered healthcare, as well as universal health coverage. And also, second, equally important, especially for ensuring quality and safety of traditional medical services. And the third objective is the promote universal health coverage through the integration. So this is the global strategy very clearly define all these objectives and directions, how we can really promote and enhance of traditional medical systems. And this is some highlight that what is the key issues and particularly for achieving the goal of the global traditional medicine strategy. So there is the issue of the lack of traditional medicine data. So as mentioned, and that many of the speakers, that information is important, especially helping the policymaker to make such a evidence-based decision making. I think there is a number of reasons that for lack of this traditional medicine data. One is the standard and systematic monitoring system, particularly for monitoring traditional system performance. So even though that some country have a data is available, but we are still have a facing that difficult comparing between the country and that each other because of that lack of standardized monitoring systems. And the second issue that research methodology, because in modern medical science that kind of randomized double-blind research methodology as considered as a golden research methodology. But somehow we also found that in traditional medicine, it is also difficult actually we directly apply of this research methodology. In order to help and support member country to strengthen monitoring evaluation systems, our region, that the traditional medicine program has successfully developed some of the standard indicator. So I think this indicator we already tested in some countries like Sri Lanka, Bhutan, Thailand, Myanmar. And I think in 2019, this year, we are going to develop and establish our regional traditional medicine portals and identify some of the focal points from the member country and let them to access these portals and update their country profile. I think this is the one way we can actually show the case how that the traditional medicine is contributing to the the overall health services. Next. And then pharmacovigilance, another our priority area is the pharmacovigilance. So in order to help the and promote pharmacovigilance systems for traditional medicine products, we have successfully developed some of the briefing note on pharmacovigilance, which is mainly targeting that the policymaker. So in this briefing note, we try to explain that why that pharmacovigilance is important for traditional medicine, and also that why it is challenging that to do the pharmacovigilance for traditional medicine products. And in 2018, we also successfully conducted a regional survey on pharmacovigilance, and the report is almost ready now. So probably those findings and outcome of this survey can guide us for the future directions, how we can moving forward this subject matters. Okay, next. Regarding this integration, in order to help the member country to understand what is the that the proper concept of the integration, we have developed some conceptual framework of integration. So from this conceptual framework, basically we're trying to help the member country to understand what possible different models of that integration in terms of the policy and service delivery level as well as customer levels. That is something. We also did conduct, regional workshops on integration in 2015 and 2017 as well. We also support many member countries to attending the international and global, training workshops on integration, especially organized by the WHO headquarters also. And in 2019, we also plan to prepare some of the regional publication specifically, discussing on these integrations. Next. Okay. So before ending my, that presentation, let me quote one of the, statement made by the our former Director General of WHO at the international conference. So she mentioned that two systems of traditional and Western medicine didn't crash, but within the context of primary health care, they can be blended together in a beneficial harmony, using the best feature of each system and compensating for the certain weaknesses in each. So from this statement, it is very clear that the two systems of medicine, either modern and traditional medicine, all have their own advantage and disadvantages. So these two systems of medicine, they can, blend together in a beneficial harmony. All this, if properly integrate together, they can actually help each other and supporting each others. So with this integrated system, people, can get benefit. They will decide, okay, which one is the best for the health condition. I think that is the, idea, scenario, how we can, promote that integration, really get the people, get benefit from this integrated system. That integrated system can be able to contribute, that achieving universal health coverage as well. Thank you very much.
Thank you very much indeed, sir, for that wonderful presentation. And now, ladies and gentlemen, may I invite Professor T.C. James, President, NIPO, a non-profit intellectual property, visiting fellow, IRS for developing countries, and guest faculty on IPR at Indian Law Institute. And he's going to present on Sustainable Development Goals for Public Health. Please put your hands together to welcome him. And may I remind you, sir, about 12 minutes, 10
Fine.
to 12 minutes.
Thank you. The United Nations Sustainable Development Goals is something which was finalized in the year 2015, rather exactly on 25th to 27th of September 2015 in New York, in a special summit of the UN General Assembly, where 193 countries, heads of the governments, ratified what the world should be in the year 2030. It is, in fact, as a wonderful title, Transforming Our World, the 2030 Agenda for Sustainable Development. This has got 17 goals and 169 targets. And it's not that all of a sudden the leaders of the world thought there should be something. For the last 15 years, from 2000 onwards, things were going on. There were the Millennium Development Goals during the period 2000 to 2015 that consisted of 18 goals, of which 3 were on health, very specifically. But in these 17 goals, one only is specifically on health. At the same time, it is linked with all the other goals also. In fact, when you look into the Sustainable Development Goals, there are 4 distinctive features you can find. The first one is the interlinkages of the different goals. Whether it's poverty, nutrition, health, education, transport, industry, or healthy cities, or justice, all are interlinked. This has been brought out very clearly in these goals. Second thing, which is again different from the Millennium Development Goals, is that financing aspect. has been addressed in this time. It was not specifically addressed in the previous Millennium Development Goals. Third one is the way I would consider the most important one. It is moving from quantity to quality. Earlier, the statistics oriented, you have to achieve this point so and so, 0.50 like that. Instead of that, here the stress is on quality of the achievement, what should be. Then, and the fourth one, where all the focus is now, sustainability. Because this is the major concern of the entire world with the climate change and other things and the kind of technological disruption, disruptive technologies, what should be sustainable. Now, coming to health, Sustainable Development Goal number 3 is the one on health. It has got 13 targets within that. But what it aims at that, health for all and wellness. Health and wellness of all ages, of all countries. It's not something very special for developing countries. It is for the entire humanity. There has to be wellness, happiness. That should be. This is the target of the health goal. And in a very practical way, we can say it is affordable access to quality medical care. That's what will decide about achievement of health for all. Now, in this matter, I would say Indian systems of medicine, our traditional medicine systems world over, they are well suited for this purpose. How? Let me explain it from the national context. Number one, when you talk about access, availability is the most important factor. In the developing world particularly, availability of medical care is a major concern. Now, this is where traditional medicine system, it is available all across the countries where they are practiced, whether it's China or India or Bangladesh, they are available. Particularly in the rural areas, in villages, they are available. And that puts them on a higher prestige. Otherwise, you'll have to go in search of healthcare facilities. There are various, WHO has prescribed various norms for that. There should be 9 hospital beds per 5,000 population, or so many doctors should be there. But when we take into account the human power, the manpower and facilities available with the traditional systems of medicine, in the countries where they are well practiced, this becomes easily achievable. Second, cost factor is what always pointed out by all the health activists. Prohibitive cost of modern health care, whether it is medicines, drugs, or diagnostics, laboratories are terribly costly. Take them out of the reach of the ordinary people. Now, earlier also, in the last panel session also, voices were expressed that when you look into the traditional medicine systems, like Unani, you would find that affordability is much more than what it is in the modern medicine. When you talk about the modern pharmaceutical companies, they would say it takes $1 to $2 billion to come out with a drug. We have drugs developed over centuries, which has stood the test of time, and there's no too much extra R&D is required into those things. That makes them quite affordable. Third, I mentioned the objective is not merely statistical, not quantity, but quality. That is, wholeness of the person. The traditional systems of medicine, they treat the whole person. They are not going into a particular molecule that would treat a particular disease. health is not mere absence of disease. It is being a healthy person, a whole person, mentally, physically, in both ways. Make them fit for the world. The fourth one is, now you will find that a lot of changes are happening in the world over, mostly from the predominance of communicable diseases to non-communicable diseases. What are these non-communicable diseases? Cardiovascular diseases, cancer, then also mental illnesses. Now, many of them, or most of them, are the result of lifestyles. Traditional systems of medicine address those issues. It talks about the whole person. The lifestyle is part and parcel of any treatment under traditional medicine systems. At the same time, it's quite suited, but there are major concerns also. The most important, which I was listening in the previous panel discussion, quality and standards. There are a lot of concern about the quality of the drugs, even quality of the services. Anybody can put up a board and start practicing. Should it be allowed? We have to create necessary confidence in the minds of the patients, the consumers. In fact, the confidence in the doctor, confidence in the system, that cures the disease 50%. If you don't have confidence, just taking the medicine is, whether it's modern or traditional, is not going to help. So in order to develop that confidence, now we have anecdotal cases here or there. Instead of that, we need to have a proper, well-established quality control mechanism. And that's what a lot of talk is about, taking Indian systems of medicine to the other countries, particularly developed countries. But they have a major concern about it, the effectiveness of the medicines. Well, we all will say there is side effects are not there. It is good, unlike the modern medicine system. But we need to prove it with the statistics. It's not necessary that you should get into the laboratory and prove it again. But you can go for absence of proper objective database in these matters. That is adversely affecting the reputation of systems of medicine, traditional systems of medicine. Good manufacturing practice. I was aghast to hear more than 9,000 pharmaceutical companies, rather units are there in India alone, of which only 13 are in the good manufacturing practices list of WHO. So this is a major concern. Unless we address this concern, it's not going to make headway. We can all, academics, government, everybody can go on talking, but the talk will not be leading to this. The sixth one, which I want to stress is, which is there in the National Health Policy 2017 also, appropriate integration of Indian systems of medicine with the healthcare system. The reasons which I mentioned earlier, they are there, but at the same time, they should be appropriately integrated. It's not that allopathic doctor should prescribe Unani medicine or Unani medicine practitioner should prescribe allopathic medicine. That's not the thing. People should be codified. You walk into a healthcare facility, you should have the option, the choice to select which one is suitable for your particular ailment at that point of time. Informed decision making with the patient, that should be available, whether I should take Unani or Ayurveda or Siddha or allopathic. I know about, because say bone setting, the Ayurvedic practices are much better than the allopathic practices and much less time it consumes. But in most of the urban areas, that facility is not available. It's there. Yeah, it's over. Yeah, I have been want, but since I normally condition myself, I am on the last sentence. So, to conclude, while traditional systems of medicines can facilitate and hasten achievement of sustainable development goal or health, it is imperative that robust and effective quality control mechanisms for these products and services should be there. Then only it can make anything. Thank you. Thank you.
Thank you very much indeed. And now, ladies and gentlemen, for the final presentation of day one of this conference and of this keynote session, we have with us Professor A. Venkatraman, who's Faculty of Management Studies, University of Delhi, South Campus, New Delhi, teaches Human Resource Management at Health Policy at the Faculty of Management Studies. His research interest is focused on exploring and leveraging public-private partnerships, option to improve equitable access to healthcare services for the poor. And he is actively engaged in advisory responsibilities with many bilateral and multilateral development partners, such as the World Bank, WHO, DFID, USAID, GIZ, BMGF, and other international agencies on engaging the private sector for health service delivery in Asia, Africa, Eastern and Mediterranean regions. And may I now invite Professor Venkat for his keynote address on health system in India, opportunities and challenges. Please put your hands together to welcome him. It's at about 12 minutes.
Sure. I hope so. First of all, thank you. Thank you, Dr. Asim, and also a big thank you for all of you who stayed back till now. I think all of you deserve a big hand of applause. Please, for you, yourself. I think I would like to start by, the last one and a half hour I was here, I've been listening to only medicine. I've been listening to how to popularize or how to make it more marketable, etc. To me, medicine is a mechanism or a kind of a delivery point where public health or health as such is the goal. And therefore, I don't care which particular system of medicine you come from, but if a particular, let's say I'll give you a couple of problems and then you suggest to me whichever medicine you come from. There is a state where out of 275 gynecologist positions, only 5 positions were filled up. Remaining 270 positions are vacant in community health centers. There is a state where they have built a hospital with 250 crore worth of investment, but they haven't been able to hire a specialist, even one specialist till now. There is a state where 80% of population live in a hamlets of 500 people. If you were to travel 2 kilometers to 10 kilometers to reach a primary health center, you will perhaps have to travel overnight. There are islands in Bay of Bengal, in West Bengal, where people don't have access to a modicum of healthcare. What is the solution that you guys are offering me as a public health person, as an economist or as a management or as a policy person? What is the solution that this medicine of, this system of medicine is going to give me? Leave that as a one point of challenge. The second point here is that health system should not be confused with only that systems of medicine. Health system is an integration of all these systems so that the public at large is healthy. Now, in order to achieve that kind of a goal, what are the possible challenges that we need to think about? Let's start with the first. These are the ones that you see the slide here. These are only limited number. They are not exhaustive in nature. At the top of the pyramid is the financing. All of you would know that India spends just about 1% of GDP in public health allocation. Within South Asia, or I should say that this is one of the lowest anywhere in the world. For such a large population, 1% of GDP to a public health allocation is, we are slightly better than Afghanistan. That's the kind of a status that we are in. As a result, what happens is that people go to the hospitals, or whether they are public or private sector, spend a lot of money. 80% of expenditure at the point of delivery of health services or at the point of purchase of health services comes from out of pocket. The meaning of out of pocket is, if 100 rupees is the bill for my entire expenses, 80% I have to spend from my own pocket. Now, where are we going wrong? How are we going to really bring about, as Dr. here Kim mentioned about, almost 7 to 8% of India's population are falling below poverty line every year due to hospital expenses. That to you may sound just about 6 to 7%. But globally, these are nations falling below poverty line. So what is the alternative? Perhaps Ayushman Bharat gives you a possible option, but we will have to wait and see what is the possible outcome of Ayushman Bharat. The second problem is related to human resources. What is the problem in human resources? We have more than nearly about 35,000 primary health centers in this country. Nearly 30% of primary health centers, which is the first door for any poor or a rural person to go and seek health care, nearly 30% of primary health centers do not have a medical officer. And what are the options? Can Ayurveda, Ayush system, can they come to really rescue these kind of vacancies in human resources? Now, within these human resources, there is also a problem of what proportion of doctors we need to have. India has one doctor for almost 1,700 population. That's in total. In public health facilities, these are 1:11,000. Now, China is about 2.7. Even if we were to move towards 1:1,000 population as a doctor population ratio, we would immediately need about 450,000 doctors. Not all of them are likely to be allopaths. So we need some medicine system, other medicine systems to come forward and become medical officers in some of these health facilities. The third problem or third challenge for us is the private sector. I do not know how many of you have been noticing the National Sample Survey Organization lately. From 1995 till 2015, the National Sample Survey every 10 years is undertaking a survey to find out where are the health services being sought. 80% of outpatient services today are provided by the private sector. About 60% of hospitalization is provided by the private sector. Now, who are these private sector? Are they only Max and Fortis? No. These are 2-member, 3-member, 1-member clinics. We recently did a paper in PLOS ONE. We tracked about 108 TB patients in the center of Delhi, trying to find out where did they go to find their services when they have the symptoms of disease. Out of 108 patients, 67 patients went to quacks, not even indigenous system of medicine people. We are not talking about Ayush people, we are talking about quacks, RMPs. This is in the center of Delhi. And why can't we step up and come forward and say that we will be the first door for such kind of a people? We are also preparing another PLOS ONE paper where we are doing a study on cross practices by the indigenous practitioners, that is Ayush practitioners. Nearly 70% of Ayush practitioners are prescribing allopathy medicine. I don't know for what reason. And that's the behavior of private sector. Because most of the Ayush doctors are in the private sector. The next challenge is related to regulation. We have Clinical Establishment Act. And this Clinical Establishment Act of 2010 has been applicable only in 5 states which have come out and accepted it. But the act has to be converted into rules. And not a single state has so far notified the rules. So Clinical Establishment Act, like for example in Delhi, the Nursing Home Act of 1952 in Delhi prohibits any clinical establishments in the residential area. Can you just tell me which particular clinical establishment in Delhi is not in a residential area? All right? That's the kind of enforcement of regulation in this country. We have forgotten to abide by the law as well as the Lord. And therefore, you see medical malpractices where a live baby is thrown into a dustbin. That's a kind of a regulatory failure that we are seeing. The next problem is related to leadership. I'm not talking about leadership only from the netas. We are not talking about politicians. We are talking about even the leadership at the lowest medical establishment level till the Director of Health Services. If any of you go to UP Directorate of Health Services office, please look at the list of directors of medical service or Director General of Health Services. People have occupied that seat for 7 days, 6 days, 1 month, 6 months. What kind of a leadership do you expect them to provide? By the time they reach there, they say that we are here to pass the time and retire peacefully. So what kind of a leadership are we talking about? Then comes the next issue, which is about the quality standards. How many of our hospitals or health facilities today are accredited, NABH accredited? How many of our laboratories are NABL accredited? I was in one of these NHM mission. I had gone to one of these cities. This was typically about the roadside fellow. So you go and test yourself for a sputum positive, whether negative for TB. Apparently this guy has a microscopy and a slide and along with some kind of a blue ink. This is typical of what a roadside practitioner does. So what happens at the end of the day is that he collects all the samples and asks the people to come in the evening. He takes those slides, dumps into the whatever yard, and sits and types half of the people positive and half of the people negative. Randomly, by name, I don't know, whatever, maybe face value, I don't know, whatever it was. This is what is the kind of a quality that we are so afraid of. Right? You heard so much of horror stories about quality. So that's our problem. The next issue is about efficient management of any health facility. The private sector is all the time talking about efficiency, efficiency, efficiency. We don't hear anything from the public sector or government departments about efficiency. That again, talks about, there is another NRHM visit, we were looking at one of the medical officer. He was saying that he was talking about account book, and he said that मुझे left side में क्या entry होता है, right side में क्या entry होता है, मुझे नहीं पता. इस साइड में एक्सपेंडिचर होता है, इस साइड में रेवेन्यू होती है, या मुझे नहीं पता है. For any 12th grade students, they know very well what's the left side and what's the right side in an account book. A medical officer is not trained. And you expect him to manage close to about 50 lakh worth of a budget. How is he going to manage it? We don't know that. Then comes the next one, which is the infrastructure. We know that in this country, the NCD demand, the non-communicable diseases, multiplying in a rapid manner. There was a time, just not 20 years back, the NCD load in India was not more than 35%. Today it's more than 50%. Now you have cancer, which is growing at a rate of almost about 16%. You have diabetes, you have cardiology problem, you have knee replacement, organ replacement industry growing up. Now where are the beds? Equipments are there plenty, but where are the beds? India has one bed for something like 1200 population. China has 3.8 beds for 1000 population. Now when are we going to create that kind of infrastructure? And who is going to invest in it? Are we going to really look for a government alone to invest in it? And the last one, the medical technology today is extremely disruptive. We have known about the teleradiology, telemedicine, teleconsultation, etc. That's only one part of it. Today, there are people who are experimenting drones for supply of medicines in remote parts of northeastern states, as well as pick up samples from such remote villages to bring it to a center for diagnostics. There are hub and spoke models which are working. Today, you don't have to really visit a far away distant clinic to know your heart problem. There are just about 12th grade lady can put in that instrument to you. The person from 400 kilometers can test whether your heart has a blockage at X place or Y place. That's a kind of a disruptive technology. Artificial intelligence is going to give you what's your grandfather's illness and what is your going to be grandchild's illness. That's a kind of a technology that we are going to be exposed to. And we still aren't prepared for even tackling the communicable disease. Now, these are the range of challenges. As I said, that these are some of the challenges, not necessarily all the challenges. Are we ready for that? Can you go to the next one, please? Slide. This is what exactly the universal health coverage concept is about from WHO. What we are providing is only that yellow colored, orange colored cube. What is not yet achieved is the entire empty space. Do we require resources? Do we require efficiency? Do we require leadership? Do we require some kind of mechanism for creating better access to the health facilities? How are we going to really achieve this? I'm not here to talk on behalf of a Unani medicine or Ayush group of people. I am coming from the other end of the spectrum and asking you to tell me where you can come in and fill in this gap. Where do you see your own role in this? And that's my major challenge I'm throwing back at you. And don't expect only allopathic doctors to think about health financing or excess or drugs and etc. You take the mantle and say how a Unani medicine person can look at health economics of this country, health financing of this country. Why do you expect a Dr. Kim kind of a person to only do an MPH? Why can't you people come forward and do an MPH and look for health problems of this country? Thank you so much.
Thank you very much indeed. And ladies and gentlemen, please once again put your hands together for the wonderful keynote addresses and presentations we had, as I once again request Professor Asim Ali Khan, DGCC RUM, to do the honors of presenting mementos as a token of gratitude and appreciation to our eminent keynote speakers. We present to Dr. Sungchol Kim. Dr. Sungchol Kim is the Regional Advisor for Traditional Medicine, WHO, Southeast Asia Regional Office, New Delhi. We present to Professor A. Venkatraman. Professor Venkatraman is the Faculty of Management Studies, University of Delhi, South Campus. And we present to Professor T.C. James, who's President NIPO, a non-profit intellectual property, visiting fellow RIS for developing countries, and guest faculty on IPR at Indian Law Institute. Thank you very much indeed. Thank you, Professor Khan, for doing the honors. And with that, ladies and gentlemen, we close the proceedings of day one of this conference, reminding everyone that tomorrow we will begin the session at 9:30. We request everybody to kindly be seated 5 minutes before that, and we would like to inform all our delegates present here that the exhibition has been arranged on the first floor of Vigyan Bhavan. We would request everybody to kindly visit the exhibition tomorrow during the day, and please have a cup of tea before you leave the venue. We look forward to seeing you all tomorrow in time for our first session. Thank you very much indeed. Have a safe journey home. Good night and namaskar.